everybody. Good evening. Thank you for joining us for week 1 of the Limb-Girdle Muscular Dystrophy Virtual Learning Series. My name is Kayla White, and I'm a Community Education Specialist at MDA. We are thrilled to have you join us today for this webinar. This learning series is part of our larger MDA community education programs, which focus on bringing the neuromuscular disease community together around education and resources. Be sure to visit the community education section on mda.org for updates on upcoming events. We are recording today's event and we'll be posting it to the website for on-demand viewing. Please know that all phone lines have been muted. We will also have a question and answer session at the end of the webinar, and you can use the chat feature to send in your questions. For over 70 years, MDA has led the way in accelerating research, advancing care, and advocating for the support of our families. MDA's mission is to empower people living with muscular dystrophy, ALS, and related neuromuscular diseases to live longer, more independent lives. Our mission comes to life through these 4 pillars. First, care. Through our national network of MDA care centers across the U.S., we support individuals and families from day one of their journey. Second, champion. Through our advocacy and education efforts, we empower families with information and resources. Third, catalyst. Through our investments in research, we are furthering advancements in treatment discoveries. And fourth, community. Through programs like Summer Camp, our Connections program, and our community events, we are helping individuals and families build supportive connections and relationships. If you haven't done so already, we invite you to join the MDA community by registering with us. I would now like to introduce today's guest, Dr. Peter Kang, a pediatric neuromuscular neurologist and physician scientist whose lab studies the genetics of muscular dystrophy and mechanisms of rare muscle diseases with the goal of discovering new therapeutic targets for these diseases. He has published extensively on these subjects, has co-edited a textbook of pediatric electromyography, and has been awarded multiple grants from the NIH and the Muscular Dystrophy Association to support his investigations. Thank you for being here, Dr. Kang. Take it away.
Thank you very much, Kayla, for that kind introduction and for the invitation from you and the MDA. I'm going to share my screen so that we can get started. Okay, Kayla, can you see that as a full screen?
Yes, looks great.
Okay, great. I'll go ahead and get started then. So we'll talk about LGMD, and I'll just go through several key topics. Let me just figure out how to advance in that. There we go. These are my disclosures. So we'll go through history and classification, diagnosis, therapies, and then community. So let's start with history and classification. So muscular dystrophies, it's been recognized since the 19th century that there are multiple types of muscular dystrophy. And even as Duchenne muscular dystrophy was being described, it was recognized that there are other children and adults with muscle issues that were a little bit different from that category. Based on what I could see in the literature, it seems like the first I could find the term limb-girdle muscular dystrophy being used was in 1953. And then the modern terminology for the general categories of muscular dystrophy emerged in the 1960s. So that's actually not that long ago. This is from a classification that was laid out in 1954. And you can see, that's quite a while ago now. You can see some terms that might be kind of familiar. There's Duchenne in there. There's facioscapulohumeral. And so there are certain terms that have ended up persisting to today, but you also see a lot of terms and names that don't look familiar, and you don't see limb-girdle muscular dystrophy in this. So if we go a little bit further ahead to 1965, then we start seeing a classification that looks a little bit more familiar, and you see Duchenne muscular dystrophy listed there. You see FSHD, and then limb-girdle muscular dystrophy is right there as number 3. And so it's really around this time that the modern classification, just in general, of the muscular dystrophies began. However, the classification was still confusing. There's this term that was used for a while, and I think early in my career I was still hearing it, called severe childhood autosomal recessive muscular dystrophy, with the abbreviation SCARMD. And that was used for a while, and even subtypes of SCARMD were starting to get described. But a lot of patients didn't really fit within this clinical picture, so that was also not working for everybody. So the next milestone was in the 1990s when various investigators began to discover genes for different LGMDs, and calpain was the first one in 1995. And so that really got people to thinking we need to come up with a better system to name these. And so there was a workshop in 1995 that came up with the classification system that was used for several decades, where you start with the dominant limb girdles as type 1 and then put a letter for each subtype. So limb girdle 1A, limb girdle 1B. And then for the recessive forms, you'd go through limb girdle 2A, 2B, 2C. And a lot of people in the audience who have specific diagnoses may be familiar with these terms and know that they have what used to be known as 2B or 2C, etc. And so that this was established in 1995 and was pretty much universally adopted. There are very few people who didn't recognize this classification system. So everything was going pretty well in terms of categorizing these from 1995 to 2016. And during this period, a large number of genes were discovered for limb girdle, and it was approaching 30 and went beyond. But then in 2016, something happened. Limb girdle 2Z was discovered. And then people realized we're at the end of the alphabet. What are we going to do for the next limb girdle subtype that we discover? So that prompted a rethink of the classification system. And then there was another workshop that happened where people talked about what should we do next. And this was in 2017, so relatively recently. And so then a new system was developed where instead of limb girdle 1 for dominant and 2 for recessive, we started calling in limb girdle D for dominant and limb girdle R for recessive. And so instead of letters to designate every genetic subtype, now there are numbers. And instead of letters, numbers have no limit. So we could go up to limb girdle R 400 if we needed to. So that solved the problem of running out of letters. So for those of you who have genetic diagnoses, you may recognize some of these genes up here. And so the subtypes change, but the genes are the same. And this is just a way to allow for further expansion and just to be able to fit future diagnoses into this classification system. And so this is just a table from that, from the article that came out of that workshop, describing how some of the older terms would be transitioned to newer terms. And so that has become largely adopted, and but I think because everyone was so used to using some of the older terms for the more common limb girdle dystrophies, some of the older terms still persist to this day. This diagram just shows some of the complexity of what we're dealing with limb girdle muscular dystrophy. Not every protein shown here is associated with limb girdle muscular dystrophy, but most of them are. And you can see that the proteins that are encoded by the genes are located everywhere in all kinds of places in the muscle fiber, from the outside to the inside to the membrane, and even in the nucleus. So we'll move on to diagnosis because that, for an individual patient, that's sort of the first step to figuring out what to do to get help. Why is genetic diagnosis important? It's important so that you can have a prognosis, so that you can have a regimen that's designed for supportive therapies and anticipate what complications might come up. Also, so that you can get genetic counseling and family planning, and then eligibility for new molecular therapies that may target specific genes and even these days specific variant types. And when I use the term variant, in some cases it's similar to the older term mutation, and in other terms it's something more benign, but I'll try to be as specific as possible when I use that term. But that is the more current genetic term that's used today. So as you recall from the prior section, 2016 was a milestone because we kind of hit a breaking point with the old classification system for limb girdle dystrophy. 2016 was also a milestone year in another respect, and kind of on a happier note, for two other neuromuscular diseases, Duchenne muscular dystrophy and spinal muscular atrophy, the floodgates opened in terms of FDA approvals for new medications. And so you can see here that there are multiple treatments for both diseases that were approved from 2016 onwards. So a lot has changed since that year, and a lot of exciting developments have occurred. So how do we treat all affected individuals? Well, there are many new molecular therapies. For limb-girdle, they're largely still under development, but they're gene-specific, sometimes variant-specific. We do need therapies that can target as many genes and variants as possible. There are no FDA-approved therapies for LGMD yet, but I'm pretty optimistic based on what's happening in other neuromuscular disorders that it won't be too long before we start seeing some potential approvals. But to get to that point and to get people access to new therapies, we need to find and diagnose all the affected individuals as accurately as possible. So what are the steps to a diagnosis of limb-girdle dystrophy? First, you want to get a comprehensive evaluation in a neuromuscular clinic. So what we see is a history and physical examination that shows muscle weakness. Typically, it's more proximally predominant. That means more in the shoulders and hips, at least at first. And then as things progress, it might get more to the hands and the feet. However, there are differing patterns. There are variants of limb-girdle dystrophy where you may see sometimes more distal weakness or, further from the middle of your body than you'd ordinarily expect. It's important to get basic tests, principally a serum CK level, and these are usually elevated in limb-girdle dystrophy. Genetic testing is now the gold standard when results are clear, and so you can do clinical genetic testing and also research studies. Muscle biopsy is useful when clinical genetic test results are not informative or if they're ambiguous. Electromyography, or EMG, has been around for a while. It's used to diagnose a lot of neuromuscular disorders still, but it's not commonly used for limb-girdle anymore. So let's get into a little more detail about genetic testing, because that's really become the mainstay of the diagnostic evaluation for limb-girdle muscular dystrophy. We have many genetic tools at our disposal. There are the old-fashioned ones that have been around for decades: karyotypes, southern blots, PCRs. And then there are what I call the newfangled ones. These are maybe developed over the past couple of decades: chromosomal microarray and next generation sequencing. I've underlined two of these: targeted sequence capture and exome sequencing. And those are the ones that are most commonly used when someone sends a genetic test for neuromuscular disorders or muscular dystrophy. It's usually these days based on targeted sequence capture technology. And then there's exome sequencing, which has sort of good coverage in some ways, but they're not completely overlapping. And on a more limited basis, there's genome sequencing that's clinically available, and also transcriptome sequencing, and then most recently, long-read genome sequencing. The important thing to remember is, at least at this point, there's no genetic test method that's perfect that can pick up every single case of limb-girdle muscular dystrophy. And these figures on the right show you kind of where things have changed. The upper right-hand figure shows a karyotype, and these are actually photomicrographs of chromosomes. And then you go down to the bottom right, and this is just a readout from an exome sequence. And you can see that things have gotten a lot more granular and sophisticated in terms of what we're looking at. So what proportion of limb-girdle muscular dystrophy can we diagnose? So next generation sequencing panels can diagnose at least 25% of cases, if not more. And that's based on a paper from 2018 that's listed here. Exome sequencing can diagnose up to 50% of cases, including ones that previously were undiagnosed based on clinical methods. And these are some representative papers that confirm that this statistic is generally what holds true. But that means that there's still a significant chunk of patients who don't have an easy diagnosis. And what's going on with those individuals? So I usually think of these in two different categories: the individuals that don't have definitive genetic diagnoses. One is the ones who have partial genetic answers. They might have one variant that looks really suspicious for being disease causing, but you usually expect two because it's a recessive disease. So people are left scratching their heads and wondering, what's going on with this. And then there are the variants of unknown significance, the VUSs, that really complicate matters significantly, because that's a very frustrating situation, because that raises the possibility you might have something going on in this gene, but we don't know for sure. And so that's a long-standing problem that we're hoping to find more answers for. And then there are the other category of individuals who have no genetic answers at all. And for those, there's still some novel genes that are being found, including some dominant ones. And then there are variant types that are not always detected on clinical genetic testing. And these include splice site mutations and structural variants. So the variants of unknown significance that I mentioned, those can be really difficult um, to get further information on. And I know that, for patients who've seen their genetic test reports, if they see one of these, it's really, you're at a loss about what to do next. Do I have this disease or do I not have it? One thing that helps is online databases. There are many more of them. They've become a lot more sophisticated, and they help you figure out, how common or rare is this variant, because that's a factor that goes into it. And if you try to model the variant on a computer, then does it look like it would cause damage? So there are all kinds of things you can find out online. And what happens in my experience is that sometimes you'll start out with a variant that's a VUS, and then it'll end up being resolved, and either gets reclassified as pathogenic or disease causing, or reclassified as being benign. There are projects such as ClinGen, which is an NIH funded project that will help resolve more of these VUSs in the future. An article that we published just last year was exploring how to use some of the latest technologies, particularly nanopore long-read sequencing, and how to diagnose muscular dystrophy. And we were able to solve a couple of cases of individuals who had a variant in one variant in a gene when they were expecting two, and other situations that were sort of mysterious based on what was available clinically. Another finding that we published a couple of years ago now is a new muscular dystrophy gene called JAG2. And it's extremely rare, at least based on what we know so far, but we're expecting that more cases will come out. And this was a report of 23 affected individuals and 13 families, and the pattern was autosomal recessive. And we see all the family trees and abbreviations for the countries where they come from. And they had both congenital muscular dystrophy and limb-girdle muscular dystrophy patterns. And so this is something that's relevant. And I think a few patients out there who did not have a diagnosis, if this gene is checked, they might find that they have this. So we are developing new knowledge all the time. And then most recently, we published a set of 4 families with a dominant muscular dystrophy. And what I've come to think recently is that a lot of these unsolved cases or patients who don't have diagnoses may have something that's dominant, because those variants are a lot harder to figure out than the recessive ones, because the recessive ones, there aren't that many variants that are paired together for a particular gene. So that kind of narrows down the pool immediately. Whereas dominant ones, you can have just one that's disease causing. So this was the original family that we came across. And we had found that the gene is DTNA, and that was just published recently, alpha dystrobrevin. And this was a family with a dominant pattern, and we found this deletion in the gene. And we were looking around for more families, and then fortunately we came across one that was found by a group in Barcelona, Spain. And so we partnered with them, and they had a very similar pattern, and their family had a variant that was right in the same location as ours. And then we found the second partner at the NIH, and they only had one individual that was affected, but there's a clear similarity. And then, the last family, which is not highlighted, is family D, which was another one in our group that we found when we were looking through and reviewing some of our data. And so we published this. And because some of the gray boxes represent patients who have very mild clinical presentations, I think some of these mysteries can be solved by looking at dominant genes and hopefully finding some more of them and more individuals in this way. So let's move on to treatment. As a pediatric neurologist and neuromuscular specialist, I can't emphasize enough how important multidisciplinary care is for someone with limb-girdle muscular dystrophy. And MDA care centers, which some of you may be going to, have long been a mainstay of multidisciplinary care for these individuals. And some of the specialties represented, and this is not comprehensive by any means. These are just examples: neurology, cardiology, pulmonary, physical medicine and rehabilitation, physical therapy, orthopedic surgery, genetic counseling, and others. Sometimes a patient will need to see an endocrinologist, for example. So it's really important to have to go to a care center where you can have somebody, the team, look at everything. So for therapies, let's dig a little bit deeper. A lot of you may know that steroids are used very frequently in Duchenne muscular dystrophy. In fact, I've seen during my career, at the beginning, steroids were used commonly, but it wasn't uniform and it wasn't standard of care, to the point where it became standard of care. And so most boys with Duchenne muscular dystrophy end up being treated with steroids, and it does help with several outcomes for those individuals. So then a natural question to ask is, limb-girdle muscular dystrophy is not exactly the same, but somewhat related to DMD. So would steroids help? And there are some case reports out there. You'll see a report of a patient here and a couple of patients there treated with steroids for one subtype or another of limb-girdle. This is the most comprehensive study that I'm aware of, and it just came out last year from Northwestern University in Chicago. And what they did was they took 19 individuals of limb-girdle dystrophy, and they had multiple genetic subtypes represented, and put them on a regimen of prednisone once a week for 24 weeks. So what they found was these individuals tolerated this. The serum CK dropped. There was maybe an increase in lean mass on DEXA scan, meaning that it seemed like maybe there was more muscle compared to fat, but it was a little bit hard to tell. The number is kind of small. And then there were trends towards improved motor function. So what they concluded was that this was certainly promising, that steroids might be helpful, at least in some cases of limb-girdle muscular dystrophy. But we need to look at this in larger groups of patients before we can really draw conclusions. So cardiac monitoring, this is something that's critical with Duchenne muscular dystrophy pretty much for all patients. But then for limb-girdle muscular dystrophy, it's a little bit different. What I generally do is I generally recommend baseline cardiac evaluations on everybody who's diagnosed with limb-girdle muscular dystrophy. So if I'm the one diagnosing them, I make the referral as soon as they're diagnosed. If there's someone new to my clinic and they were diagnosed previously and they've never seen a cardiologist, I'll refer them then. But then what happens after that is a little different. Whereas in Duchenne muscular dystrophy, almost everybody beyond a certain age especially gets ongoing monitoring. With limb-girdle, it sort of varies a little bit. If your baseline evaluation shows any abnormalities, then you definitely need to have regular follow-up from that moment on. We also know a little bit about the different risk profiles. There are some subtypes that are really known to have cardiac complications, and others where it's rare, and others where it's really unheard of. So these are some of the subtypes. And again, this list is not meant to be exhaustive. There are some subtypes where it's been pretty well documented that heart complications occur, but there are others where they occur as well. These are just some of the classic subtypes. There are two subtypes, especially LMNA. That one is really widely known to have very high rates of cardiac complications. These two subtypes have been reclassified as different types of muscular dystrophy based on the most recent classification system. But a lot of us still think of them as limb-girdle 1B and 1C, so that's why I mention them here. And there may be people in the audience who have these diagnoses. Pulmonary monitoring. So similar to cardiac monitoring, we recommend baseline pulmonary evaluations on all of individuals with limb-girdle muscular dystrophy. And then ongoing monitoring, again, should be determined by the findings on baseline evaluation and risk profile of limb-girdle subtype. One point that's a little different from the cardiac side, I would say any individual with limb-girdle muscular dystrophy who's at a non-ambulatory stage is automatically at higher risk of respiratory complications, and those individuals should have regular monitoring. And it may only be once a year, but it's nice to be on a regular schedule just to keep an eye on things. So what new therapies are being developed? The MDA conference that just took place last month was a really good source of information, and there's a lot of exciting developments for limb-girdle muscular dystrophy. And then clinicaltrials.gov, which is a public NIH-funded resource, provides a very comprehensive list. In the United States, it's actually required to have a listing on clinicaltrials.gov to have an officially sanctioned clinical research study, especially if you're looking for FDA approval of a new therapy. So that is an authoritative resource. It's very comprehensive. So this is just an example, and I'm sure there are others, but these are some examples of some ongoing or recently completed studies. So I mentioned before that steroids are being looked at a little bit more carefully as a therapy for limb-girdle muscular dystrophy. So deflazacort, which is another compound, has been studied for limb-girdle R9/2I, which is FKRP, and we're waiting to see or hear more results from that. There's a compound called ribitol, which has been developed specifically for limb-girdle R9/2I, and that's listed on clinicaltrials.gov as well. It's a phase 3 study. The company has already finished preliminary studies in humans. It's not recruiting yet, but there's anticipation that it will in the coming months. And then gene therapy, which I know has been in the news a lot and a lot of you have heard about, has been very active for limb-girdle muscular dystrophy recently. So there have been clinical trials for type R2, R3, which are dysferlin and alpha-sarcoglycan, and those are completed. And then there are trials that are ongoing for type R4 and R9, and those are recruiting according to clinicaltrials.gov. And then on top of the gene therapy, there's cell therapy, which is still in preclinical development, but I anticipate that there will be some clinical trials for this also. So the future is bright but complex, and the way that that I and many others have started thinking about this is that we probably are not going to find a single magic treatment that will dramatically transform this disease. However, there's a lot of hope that we will be able to come up with multiple therapies. Some of them may need to be given in combination that together will have a dramatic impact on the patients and their qualities of life and life expectancies. So we're very optimistic about the future. The future is fairly complex because there are all these strategies and they probably will be overlapping and patients may need to be on more than one. So the last topic is community. And I think it's really important, given that LGMD is an ultra-rare disease, for there to be a community with everyone talking to each other and helping each other out as much as possible. And we really all need each other. And these relationships, I think, have become much more robust during my career, which has spanned now 20 years since I finished my training. I think there's much more open dialogue amongst all of these entities. And of course, patients come at the top of the list, and then their families. There are multiple types of healthcare providers. There are physicians such as myself. There are also nurses, physical therapists, genetic counselors, and others who are involved in the care of these individuals. There are scientists who are trying to come up with new therapies. And the sophistication of the science that's going on right now is just mind-boggling. With all the variants of gene therapies that are being developed, different virus vectors, different genes to be put into the vectors, different components. And the other therapies that are being developed, the level of sophistication of these therapies is really increasing dramatically. And then there are government agencies, and these include the FDA, which approves all therapies in the United States, the NIH, which provides a huge amount of funding for muscular dystrophy research, and the CDC, which does epidemiologic surveillance for muscular dystrophy. That's been very valuable in giving a window onto what's happening in the United States with muscular dystrophy. And then industry partners, there's a lot more activity from the biotechnology industry and the pharmaceutical industry on trying to find more solutions for the limb-girdle muscular dystrophy community. And so this has become a much more robust relationship or set of relationships among all of these entities. So where would I go for more information? Well, the MDA has been around for many decades and has really a long history of supporting patients and families. So one place definitely to go is the MDA website. Another MDA related resource, if you have access to one, is to go to your local MDA care center. And if you're a patient there, then you probably already know people there that you can talk to. If you don't, then hopefully they can accept you as a patient, and you can start a dialogue with the individuals there. Clinicaltrials.gov is a very useful website. It does have a lot of information, and so it does take a little time to go through. When I looked earlier today, I found 50 listings for limb-girdle muscular dystrophy. So that is actually a lot. And there are more listings for some other diseases, but 50 is a pretty good number. So it's a lot to go through. The Speak Foundation supports families with limb-girdle muscular dystrophy also, and their website and their newsletters are very helpful. There are really numerous foundations worldwide, in the United States, of course, but also in other countries around the world for limb-girdle muscular dystrophy in general, and then specific subtypes of limb-girdle muscular dystrophy. And then there are clinical research consortia, such as GRASP LGMD, which is based at Virginia Commonwealth University, but has sites all over the United States and a couple overseas. So for anyone interested in more information on our research, you're welcome to email me. And then the Neurogenetics Biorepository at our institution, the University of Minnesota. For anybody who's interested in our genetics research, you're welcome to contact us at one of those email addresses. This is just a photo of people in my lab who did some of the work that I presented earlier in the presentation, and then a listing of lab members. These are both clinical and research colleagues at the MD Center at the University of Minnesota, and this was us at the recent MDA conference in March. And there are many individuals that are very talented in that group. And then I do want to thank the support of the MDA and many other organizations supporting our work, both in the clinic and in the research realm. And I'll be happy to take questions at this point.
All right, Dr. Kang, so I've been watching the chat, and we do have some questions that have come in. We'll just kind of start with the very first one that came in, and it says, if my test was conclusive, but it was done using the PCR method, should I look into getting retested?
If your genetic test was pretty conclusive, even if it was 20 years ago, that should be good enough if that has enough detail about what the variant or mutation was. So I would definitely talk to the physician who's primarily taking care of the limb-girdle dystrophy issues, and just make sure that the information you have is the most accurate possible. But yeah, we still rely on genetic test reports from 20 years ago. The times when we recommend that patients go through a retest is when they have ambiguous results or negative results. Especially 20 years ago, a lot has changed. The panels have expanded. The exome testing has really enabled us to detect a lot more. But if you and your physician are fairly convinced that you have all the information you need, then you should be all set.
Okay. I was diagnosed with LGMD in 2000 by muscle biopsy. How do I get genetic testing done?
So if you have access to an MDA care center, that's a good place to go. And genetic testing has become a lot more accessible. If you live in the United States, there was a period when it was really expensive. And I remember that I was trying to be really careful about trying to figure out what the gene was that was likely the one involved and sending testing for that one particular gene because I didn't want to send really expensive testing. Nowadays, genetic testing, it's still on the pricey side, but it's nowhere near as expensive as it was when I first started my career. So if you don't have a genetic diagnosis and you've never had a genetic test, you definitely should have one. And I would say to go look on the MDA website for your closest MDA care center. If you don't have one near you, I would try to find the neuromuscular neurologist and either adult or pediatric, depending on the age range. I'm guessing that the person asking the question is an adult, so it's probably an adult neuromuscular neurologist that you'd want to try to find if you can't find an MDA care center nearby.
All right, thank you, Dr. Kang. How do I find out what type I have? I was diagnosed in 1996 and am 72 years old.
Oh, I think the answer would be similar. If you were initially diagnosed with a muscle biopsy, sometimes on a muscle biopsy, you can get a hint of what subtype you have. For example, there's a set of genes called the sarcoglycan genes, and you can do some staining on the muscle biopsy sample and get a hint of which gene it is. But to really get a definitive answer, genetic testing helps. And these days, the panel testing has become a lot less expensive than before. So it's very easy. If you find a physician who's comfortable sending this testing to have a whole panel sent that could have as many as 100 genes in it. And sometimes some people just go straight to exome sequencing. So it depends on the situation. But yes, I would recommend anyone who's in the audience who has a diagnosis of limb-girdle muscular dystrophy but has never had genetic testing. It's very worthwhile to do so. It doesn't matter what your age is or how long ago you developed symptoms. I think it's helpful information to have. And also it's helpful information if you do have any children or other descendants for them to have that information as well.
Great information. Thank you. Let's see. My son was diagnosed with LGMD type 2E. What is the prognosis on the lifespan?
So I try not to be too specific about life expectancy, and there are, at least for some subtypes, some statistics out there. And the reason I don't is that everything is changing so dramatically. And so if I were to give a number, by the time your child reaches that age, I think that things will be different. So I don't want that to be something that a family dreads or feels that is kind of a dead end, because we know that there are life-threatening complications that happen, and so these children are at risk of dying earlier than you would otherwise. But the care is improving almost daily, and so I prefer not to have put a specific number to it right now, because I think things are changing, and they are changing fairly quickly.
That makes a lot of sense, Dr. Kang. Let's see. Is it possible to have been misdiagnosed with the type of MD I have?
That is a possibility. I think going back to that topic of the variants of unknown significance, or VUS, especially when genetic testing first became available and there was less familiarity with the different types of variants, I think there are some cases that I've encountered where somebody interpreted a VUS as being a definitive answer and said, you have this subtype of limb-girdle. But then when we look back on it, it actually was more ambiguous than that. So unfortunately, there may be a few cases here and there where the wrong subtype was assigned. If you have a real concern about it, I would talk to the whichever physician is primarily in charge of your case and see if repeat testing is something that could be arranged if it's appropriate. And it depends a lot on the circumstances, how long ago you had the testing, what your insurance will cover. It is important for genetic testing. I do want to make a note to make sure that you know what the coverage is as much in advance as possible. Although the cost has dropped significantly in recent years, it's still several $1,000s in some cases. And so you do want to make sure you check into coverage.
Do any types of LGMD cause enlarged muscles, specifically in the calves?
So that's been documented here and there in some subtypes. So I think it's something that if you see enlarged calves, a lot of times it suggests Duchenne or Becker. Obviously, if the patient's a female, then you know that it's likely not Duchenne and Becker, and so then you're already thinking about limb-girdle muscular dystrophy. And then there are also boys who get limb-girdle muscular dystrophy. In general, it's a roughly even distribution, males to females, in limb-girdle muscular dystrophy. So I would say if you see enlarged calves, depending on whether it's a boy or girl or man or woman, you might want to think first about Duchenne or Becker, but in some cases it may be limb girdle. So yeah, it definitely is consistent with some cases of that disorder.
All right, our next question is asking about your opinion on exercising. Someone practices pickleball 8 hours per week, and sometimes I feel tired and have pain in my legs, but I can play and even compete. So just what are your thoughts on that, on exercise?
So I think I kind of go by the old motto or advice of choose the mean between the extremes, and so you don't want to be completely sedentary if you can avoid it, and if you have limited mobility, try to be as mobile as possible. But at the other extreme, you don't want to exercise so much that you damage your muscles. So the what that mean is that that magical moderate amount of exercise differs from individual to individual. It is important to listen to your body because your body is telling you information and giving you clues. So if you're developing cramping or pain, then you should probably stop whatever you're doing. And if it's a consistent occurrence, if you know that after 20 minutes of activity, whatever that activity is, you start to develop cramping and pain, you probably should just stop at 20 minutes. And that number may change over time, or that limit, and it differs from individual to individual. I work very closely in clinic with a physical therapist and also a rehab doctor, and colleagues like that can help a lot in terms of providing guidance. I provide guidance also, and they provide more detailed guidance sometimes than I can. The one complication, this brings up something, this doesn't happen often in limb-girdle muscular dystrophy, but there is a complication called called rhabdomyolysis, where your muscles start breaking down if they become too stressed, and then the protein from the muscle breakdown spills into your urine and turns it red or brown colored. So if that ever happens where your urine turns red or brown colored, then you should go seek care immediately, preferably at an emergency room, because you may need IV fluids to flush out your kidneys, because the protein that goes into your kidney can cause kidney damage in a worst case scenario. So again, it doesn't happen very often, but you do want to make sure when you do exercise, you stay hydrated as much as possible, and that you listen to your body. If you feel cramping or pain, or a lot of fatigue, you should stop and then kind of use some of your body's cues to guide you on what's tolerated. And in general, we recommend avoiding contact sports. You don't want sports where you could be bruised or knocked over or things like that. Cardiopulmonary exercises are good. Swimming is good. If you do have some limited mobility, you do want to make sure that you have some supervision in the pool and one-to-one supervision, so that you don't run into trouble if you develop a sudden cramp or become suddenly fatigued. So, but with those kinds of caveats to ensure safety, something like swimming is an excellent activity. Walking or light jogging, things that where you don't necessarily have a direct trauma to your muscles or body. As much as you can tolerate and that your body tolerates, I recommend a moderate level of exercise.
And someone actually just asked in the chat if yoga would be a good exercise.
I think yoga is excellent. I would just be careful with the types of maneuvers. If some patients with muscular dystrophy do have a little bit of joint laxity, and so you want to make sure that any maneuvers you do are not increasing the risk of a joint dislocation. So, and then also there are risks of fractures sometimes, especially if you happen to be on steroids. So I would say yoga sounds like a good idea. I would just be very careful and not push that too hard in terms of maneuvers.
Okay, excellent. A couple of questions about cardiac issues. What are some documented cardiac complications for patients with DYSF, and how soon after diagnosis could symptoms appear?
So cardiomyopathy is something that we worry about, and that can be detected by principally by echocardiogram. These days, we also do cardiac MRI, which can pick up more subtle findings with the heart. And so we look for, and EKGs are also important. And sometimes we do see rhythm disturbances, but we mostly worry more about structural problems. So the things we look for are whether the heart's starting to enlarge and is it having more difficulty pumping blood. And so it's good to get that baseline evaluation. And then once in a while, depending on what your subtype is and what the first evaluation looks like, look at it over time. And so if you have a certain ejection fraction, meaning how much blood you can pump out at once of your heart, see if that starts out normal, will it stay normal? And or if it's still normal but declining, that then you want to keep a closer eye on that. And so there are medications that can be prescribed by a cardiologist to try to slow down the progression of that. And so I think it's important, if you've never seen a cardiologist, I would recommend you see one at least once. And depending on the situation, you may need some ongoing monitoring. And it may not be that often that you need to be checked, but it depends on the situation.
Okay, excellent. Someone asks, for older adults who are still ambulatory, would steroid supplements be advisable?
That's tricky. I think in older individuals, the older adults, there's an increased risk of osteoporosis, and chronic steroids do have that side effect of causing increased risk of fractures. So I would say discuss it with your physician. It's something that's not standard of care right now for limb-girdle muscular dystrophy. So I'd be a little cautious about that. There are other chronic side effects of steroids that are also not ideal, such as potential weight gain, and then other changes in your body and your metabolism that could cause long-term complications. So it's something that's worth thinking about. It's certainly worth asking your physician about, but I wouldn't automatically jump to it. And there are, I think, certain risks in an older adult population that's different from pediatric or young adult populations.
Okay, so the next question, it seems like someone is getting some differing opinions on the type of LGMD that they have, about whether or not it's inherited from mother to son or from both parents, and wonder what your advice would be on getting that clarified and how to move forward in that situation.
So, one professional who's very helpful with questions like that is a genetic counselor. So, with my training and background, I'm pretty comfortable talking about the risks of passing things along to children, and whether it's depending on whether it's a son or daughter, and issues like that. But not everybody is, and genetic counselors have special training to discuss these very issues. And so, if you have access to a genetic counselor, either through an MDA care center or through another clinic, then by all means, that would be a really good place to start, or a good person to start with. And it could be one of those situations where you have an ambiguous test result, and so you may need to get retested or have further evaluations like a muscle biopsy. But yeah, I think if you have any concerns about risks of passing on particular variants to children, you definitely need a professional opinion about that, just to make sure you have the best information possible.
All right, we have several questions that have come in about dietary advice for patients with LGMD, and some people are looking to get help gaining weight, some people are looking to get help losing weight. So what kind of dietary advice would you have?
So there aren't set dietary guidelines for limb-girdle muscular dystrophy. I think it is helpful to have at least a moderate intake of protein, um, and complex carbohydrates. This is sort of similar advice that I think would apply to anybody, but I think they're probably a little bit more applicable to limb-girdle muscular dystrophy, because your bodies are probably a little more sensitive. So, a moderate amount of meat and fish, and then complex carbohydrates versus are probably better than simple carbohydrates. And I would recommend avoiding sugary drinks. Very fatty foods are probably not ideal. Your muscles are accumulating fatty deposits during the course of this disease, so I think you don't want to add to that burden. So there are also, I should have mentioned, in our clinic, we have a dietitian who sees some of our patients. And so if you have access to a dietitian in a healthcare setting, it's definitely worthwhile to get a professional opinion, because a dietitian can really get very specific about what foods are better versus not better within those categories. And so, or, how certain foods would fall into certain categories. If you're not sure what counts as a complex carbohydrate versus simple carbohydrate, a lot of that information is available online, but still, I think it's helpful to get a professional opinion from a dietitian about what foods to try to increase and which ones to avoid.
All right, thank you. So someone has asked about their son, who was one of the 23 individuals identified with the JAG gene 2 years ago.
Mm-hmm.
Has there been any further information of its reach in others, and what is the best way to stay up to date on that type of LGMD?
So, um, I have not seen a lot of reports of the JAG2 since our publication in 2021, and as you probably know, this was a collection of people from all over the world. And so, if you're not already enrolled in our biorepository, you're welcome to reach out and contact us, and we'd be happy to enroll you. And we can do that remotely, so that you'll be in our database. My laboratory is doing active investigations on JAG2. We haven't published additional articles since that one, but we are doing work on it, and we're also seeking funding for that work. So it is something that I'd like to find out more about. I do want to help those individuals as much as possible. So if you're comfortable reaching out to me or my team, you're welcome to do so, and then we can discuss further.
All right, thank you, Dr. Kang. Someone has asked if stress fractures are related to LGMD2L, or if there are any other kind of foot complications that are common.
Stress fractures can occur in any type of muscular dystrophy. The risk increases if you go on steroids, but because of the limited mobility and metabolic changes that happen in your body, even without the steroids, there's a little bit of an increased risk. So I would, take certain precautions. As I mentioned, try to avoid contact sports and avoid really heavy lifting, and then try to and also you can talk to a physical therapist who's on one of these teams, multidisciplinary teams, to get more detailed advice about what kinds of activities may be higher risk for stress fractures. But contact sports and heavy lifting would be two obvious ones. I do also recommend that individuals with muscular dystrophy avoid weightlifting, especially with free weights, because that can be a little bit dangerous. So if you do any, I would say very, very minimal weights, and preferably with the machines rather than with free weights, just to reduce the risk. But yeah, I think the idea about moderate activity and not going too far towards heavy activity would help reduce the risk a bit.
Let's see. Someone has talked about they've gone through several neuromuscular panel tests over the past 10 years, all of which have come up negative. And they're wondering if the ClinGen site or other groups have a better chance of diagnosis.
So I don't know that ClinGen interacts directly with patients. They have a website. If you Google ClinGen, you should be able to find them pretty quickly. So you can try. You're also welcome to contact us, because we are actively looking at undiagnosed patients with limb-girdle muscular dystrophy and trying to figure out what's going on with them. So you're also welcome to contact us. There are multiple centers around the world that have the same interests. So if it's more convenient for you to go somewhere local, you're welcome to do that. But as I mentioned before, we do remote enrollment. So especially if you're in the United States, it's very easy to enroll. And overseas, we are also able to under certain circumstances.
Someone has a nephew that has LGMD, and he can no longer walk and can barely move his arms. And they're curious if you have any suggestions on how to help him get better mobility.
I'm hoping that your nephew is seeing a physical therapist on an ongoing basis, and it's important to have that ongoing relationship because the physical therapists do some exercises during a therapy session, but they also give you advice about what you can do at home in terms of exercises, and then also if there are any device needs such as orthotics, they can help, and they typically work with device specialists who can help with wheelchairs. I think it's important to try to maximize mobility to whatever extent is possible, obviously without causing pain or distress. So, you want to tailor any kind of exercise to the individual. So, but whatever your nephew can tolerate, I would just have both passive and active exercises and work with the guidance of a physical therapist or a rehabilitation doctor. A physical medicine and rehabilitation doctor is a specialized type of physician who works on these issues in particular.
All right, I think we have time for just a couple more questions. So someone is wondering, they've done extensive research on both sides of their family and don't find anyone with signs of muscle weakness, but would it do any good to do the genetic testing at age 64?
If you or your physician are convinced that you have a form of muscular dystrophy, then I think it's worth looking into this more. It sounds like may have had multiple rounds of genetic testing. It didn't show anything. One possibility would be to undergo a muscle biopsy, but that is a surgical procedure. In some centers in adults, they can do muscle biopsies under local anesthesia. So it depends on where you go, what circumstances they can be done in. But if you've had multiple rounds of genetic testing and you have ongoing issues that are suspicious for muscular dystrophy, that's a situation where I think a muscle biopsy might be helpful. It won't usually give you the subtype of muscular dystrophy, but it can at least tell you if there's something really significant going on in your muscle.
All right. And so our last question is someone has asked about family members. Their family members seem to have kind of issues with different areas. And so their question is it possible that my disease may progress more in one area without affecting other areas, such as my heart, but not my shoulders and hips as much?
Yes. So one thing that makes it tricky to take care of patients with these types of disorders is that the progression can vary a lot from organ to organ. And that variability, sometimes it's to some extent predictable by subtype. So for example, if you look at the LMNA gene, which I think some people now regard as exclusively Emery-Dreifuss, but at least previously it was considered also part of limb-girdle muscular dystrophy. That's a gene where you have a very high percentage of individuals with cardiac complications, and sometimes the cardiac complications come first. And then at the other extreme, there are individuals who have muscle weakness their whole lives and their heart is totally fine throughout. So but even within subtypes, you have variability. So I would say start with the subtype and find out as much as you can about what to expect based on the subtype, and then try to figure out what your baseline status is of your heart, if that's what you're most concerned about, and that way it can be tracked and followed closely. What I try to do in my clinic is to make sure that everybody is regarded as an individual. When I look up articles and I look up statistics, I use those as general guides, but I really try to hone in on the individual patient because everybody's a little bit different. And so it's important to just get a sense of what's going on with each individual.
All right. So we are coming up on the end of the hour. So Dr. Kang, thank you so much for this session. It was such wonderful information, and I know that everybody found it very, very helpful. Again, we just appreciate your time, your expertise, and everything you do for the neuromuscular community.
Well, thank you very much to the MDA, and thank you to everybody who attended. It was really nice to converse with everyone.
Thank you, Dr. Kang. So just a few housekeeping notes to wrap up. If you are new to MDA and are diagnosed with a neuromuscular disease under MDA's umbrella, or are a loved one of someone who is diagnosed, we encourage you to stay engaged with MDA. You can do this by visiting mda.org/join and completing a short form. Joining is free and will keep you up to date on the latest research, educational programs, and supports. So we would love to hear your comments about this webinar. This is actually our very first virtual learning series. It's our very first session. So Dr. Kang, we thank you for kicking that off for us. If you have a smartphone, you can open your camera and point it at the QR code on the screen, and a web page will pop up with a short survey about today's webinar. If you don't have a smartphone, once the webinar is over, a screen will pop up with that survey as well. So if you have any questions after the webinar, please feel free to email them to mdaengage@mdausa.org, and we will follow up with you. And so this concludes the first week of the LGMD Learning Series. Well, thank you all so much for attending. We hope to see you next week for week 2. Thank you all.